in the best place. And I just got to say, guys, I just came back from our Orange County Health Equity and Data Summit. So, and I was just so inspired there because they were all talking about the work we do and how important it is to collaborate and to work together and to not silo and to make sure we're not duplicating, but also that people are getting the best services and that we're able to talk to each other. So I just want to thank everybody for taking the time to come together in this training series. And even though we're not in the same room, learning to collaborate with each other, getting to know leadership from the other teams, so that you know that if you're having a problem with housing, that you can reach out to Trish, or if you're having something going on with care coordination, you can reach out to Caitlin, Trish, or Nicole, that Barbara is here for our social programs, and that those leadership are all working together to make sure our shared clients are getting what they need. So I want to thank everybody here today. And with that, I'm going to get started. Right, I think I have to share my screen first because unfortunately I only have one screen. So before I share, I'm going to introduce Barbara because I'm not sure if I'm going to be able to see all of you once I share. So Barbara is fairly new to us, but certainly not new to this work. She has a long history, several decades of working with our forensically involved population. So has a wealth of knowledge about the area as well as service delivery. And as you can imagine, working with that population for as long as she has had to do a lot of motivational interviewing, which is what she's going to talk about today. She's mostly housed in our Hudson House office, right behind the big TV, which thankfully is off for this presentation she's shared with us. But you can also find her in Middletown, sharing an office in the back with Katie, our Director of Clinical Operations. So I'm going to hand it over to you, Barbara, now as I share my screen.
Good afternoon, everyone. You made me sound so old, Allison. Oh my gosh.
Not old. You just have done this work for, I don't know, your entire life. I think out of the
Yes.
one, I think is it.
I think you're right.
So, all right. So I think your presentation, everybody be able to see that now? It should see our presentation team, which I talked about already. And this is our agenda. We're going to be going over some basics. And here we go. Is this the screen you want to be on, Barbara?
Yes. So our agenda is we're going to talk about motivational interviewing. We're going to talk about ORs. We're going to watch 2 videos, and then we're going to talk about any questions that you might have. Can I move it along? Oh, okay. So let's get the definition of motivational interviewing. It's a counseling approach that aims to help individuals resolve ambivalence and enhance motivation for change. It involves empathetic listening, asking open-ended questions, and reflecting back on what the person has said to help them explore their own reasons for change. So some examples of that are open-ended questions, which encourage expression and sharing of perspectives. Affirmations, so they affirm the client's genuine skills and strengths. Reflective listening. Reflect the client's statements to check for meaning, and then summarizing. Recap the sessions to come to a shared conclusion. Can I move it? Oh. So open-ended questions. Open-ended questions draw out and explore the person's experiences, perspectives, and ideas. Evocative questions guide the client to reflect on how change may be meaningful or even possible. Information is often offered with the structure of open questions, which elicit, provide, and then elicit. That first explores what the person already knows, then seeks permission to offer what the practitioner knows, and then explores the person's response. The affirmation is an affirmation of strength, efforts, and past successes to help build the person's hope and confidence in their ability to change. Reflections are based on careful listening and trying to understand what the person is saying by repeating, rephrasing, or offering a deeper guess about what the person is trying to communicate. This is a foundational skill of motivational interviewing and how we express empathy. Summarizing ensures that understanding and reinforces key points made by the client. Attending to the language of change. It identifies what is being said against change, that's sustained talk, and in favor of change, which is change talk. And where appropriate, encouraging a movement away from sustained talk towards change talk. Exchange of information respects that both the clinician and the client have expertise. Sharing information is considered a two-way street and needs to be responsive to what the client is saying. MI is framed as a method of communication rather than an intervention, sometimes used on its own or combined with other treatment approaches. There are a number of benefits of learning MI amongst other approaches to help conversations. MI has been applied across a broad range of settings: health, corrections, human services, education, those populations, age, ethnicity, religion, sexuality, and gender identities, languages, treatment format, individual, group, telemedicine. I'm sure we all experienced a lot of telemedicine when COVID happened. We learned how to use Zoom, right? And presenting concerns, whether that's health, fitness, nutrition, risky, sexual behavior, treatment, adherence, medication adherence, substance use, mental health, illegal behaviors, gambling, and parroting. MI compares well to other evidence-based approaches in formal research studies. MI is compatible with the values of many disciplines and evidence-based approaches. Although the full framework is a complex skill set that require time and practice, the principle of MI have intuitive or common sense appeal, and core elements of MI can be readily applied in practice as the clinician learns the approach. MI has observable practice behaviors that allow clinicians to receive clear and objective feedback from a trainer, consultant, or supervisor. So I'm sure if you've heard anything about motivational interviewing, you've heard about OARs. So the 4 skills of motivational interviewing, the O stands for open questions, and that promotes trust and enhances communication. For example, an open-ended question would be, what concerns do you have? The A is for affirmations, validate positive attributes, efforts, etc. For example, you've done a great job with. I mean, who doesn't love to hear you've done a great job? Reflections, that's what the R stands for. Demonstrates active listening and invite exploration. For example, I see this upsets you. And that's where you would see that nonverbal communication come in, how our clients are reacting to what we're saying. And the S summarizes. The bundle concluding reflections invite elaboration. Oh my gosh. For example, let me summarize what I heard you say. Please let me know if I'm correct. So when we're using motivational interviewing, all of these things can happen. So we're engaging, we're working towards a goal, we're addressing a problem. We might be talking about counseling, orientated, positive, con. So if someone has a con, right, we're going to try to move them towards change. So all of these things can happen. Hopefully they're not going to happen at once. That would be wonderful if they did, but they can happen. And that's what we want to do with our clients. So you're going to see some videos on motivational interviewing in action. I apologize for the age of these videos, but it does show.
I just paused my share because I wasn't sure if I shared the sound. I'm just resharing. Didn't go away, don't worry.
Perfect.
I forgot to check my little boxes. Okay.
Well, hey, Miss Clark. My name is Alan Lime. Dr. Seal asked me to talk to you about your drinking.
Okay.
Yeah, he said that you filled out the form and that you came to him for some medication for your stress, but that he was really concerned about your alcohol consumption before he made any prescriptions for you. So let me see that form, please.
Okay.
Thanks. Yeah, well, it says here that you drink 4 more times a week and that you have 1 or 2 drinks and that you go over that limit on a fairly regular basis. That's too much. That's too much. I mean, I imagine that he's already told you that he can't prescribe you anything unless you do something about this drinking.
Okay. I'm really confused. He did want me to come and talk to you. I'm just not real thrilled with the way this is going.
Well, I'm sure you're not, because anybody that drinks at these levels isn't going to be thrilled talking about their drinking with a professional like myself. And what we know is that if you continue to drink at this rate, you're probably going to wind up drinking more and more. And I imagine that's his concern, is you can
I
wind up to be an
didn't think I
alcoholic.
was drinking that much. I mean,
Well,
1 or 2 glasses of
Well,
wine
how
a
big is the
night.
glass? I mean, this is a typical glass, which is 5 ounces of wine. But what I know is that most people drink a lot more than that. So
Well,
I'm pretty sure that your glass is bigger than that one, wouldn't you say?
you're not in my household. You don't know what I drink.
Yeah, I know,
It's about that size, maybe a little
I've never been in a
more.
house where they have these stem glasses. That's only at restaurants. Most people have tumblers, so I imagine that's what I'd find if I opened your cupboards.
Yeah. Oh, no.
Well, anyway, so what he said was that you came to him for some kind of benzodiazepine, something for anxiety, and we can't prescribe anything like that if you're drinking at these levels. So we need you to stop, or at least cut back to reasonable levels, which for you would be no more than 3 drinks in one setting, which you're drinking over that now, or no more than 7 drinks in 1 week, which you are well over right now. So if you can agree to that, then perhaps he can make that prescription for you. I can't promise that either, but that's certainly one thing. The other thing you need to do is to read this, take this pamphlet and read it, and you'll see in there that it tells you about limits of alcohol, and I think you'll find that if you can stick to that, you should be okay. He may be able to prescribe you the medication at that point. I'm not sure, can't promise. But if you do have problems, and I suspect you may have problems cutting back to those levels, then we can make a referral for you to a counsellor to come and talk about your increased drinking. So, you have any questions for me?
No questions at all.
All right, well, thanks. And I'll tell Dr. Seal that you came in and that you were reasonably compliant and that you said you'd follow through.
You can tell him whatever you want.
All right, thanks. Well, hey, Mr.
Okay. Can we go back to that other slide? So, wait, one more. Thank you. So did you notice her body language? Did anyone notice the way she was sitting? Okay, so her body language, right? Her tone, the feeling of being judged. Many years ago, I worked in the field of HIV and AIDS, and I used to work with clients, and I would go to doctor's appointments, and I had a client that was going to the doctor. She was overweight, and they would make her get on the scale at each visit, and the doctor would say to her, "You need to lose weight." She ended up being almost unable to go back to the doctor's office, which would have affected her medical care. It would have affected the HIV virus that was in her system. And ended up speaking to the medical provider, and I said to him, you really need, and it took a lot for me to be able to speak to a medical provider like this. And I said, you can't talk to her that way. I said, you really need to come at her a little differently and be able to address what you need to address. When she's ready to talk to you about the other things, that'll come into play. He listened to what I said, and I talked to her and I got her to go in like one more time to see him. He and she had the loveliest conversation. He was slightly overweight himself and really said to her, I'm really sorry that this happened. It ended up being, he became like her favorite medical provider. So by him just changing and changing the way that he was actually speaking to her, really helped her to move forward in her medical care with him. So that was a real positive one for me for motivational interviewing. Now we're gonna see the better version of this.
Well, hi, Ms. Clark. My name is Alan Lime. I'm a social worker at the Family Health Center. Dr. Seal asked me if I would spend some time with you today. I'm really glad that you're here. I'm just curious as to why he would send you to me.
Well, I came to see Dr. Seal last week because of increasing stress and anxiety that's kind of getting the best of me. And in the course of my appointment with him, he was asking how I was dealing with that stress. And I mentioned that my 1 or 2 glasses of wine a few nights a week is turning into more frequent and maybe 3 or 4 on some nights.
Okay.
And he had some concerns about that and felt like maybe you could help me with stress or something.
Yeah, so he asked you to see me because you went to him for increased stress, and he's concerned that your alcohol consumption may be a part of that increase. And prior to prescribing you anything, he wanted to make sure that you at least had someone to talk to about that.
I suppose.
Okay. I saw that you filled in one of the pink sheets. May I take a look at that?
Yeah, he told me to fill that out and bring it with me.
Okay, thank you. You say here that you have 4 or more drinks in 1 week. You mentioned that you may be increasing that a little bit as well, and that you have 1 or 2 drinks in one setting.
Typically.
Yeah, and that maybe monthly you have more than that. What kind of drinks do you have? What do you drink when you typically drink?
Wine with my meals. Again, 1 or 2 typically, and more frequently 3 or 4 since my stress has increased.
So it's starting to increase. You're starting to drink a little more. Okay. Well, based on what you put here, it gives you 6 points on this scale. The scale ranges from 0 to 40. So 6 points will put you in what we would consider an at-risk zone. So if it's okay with you, let's just talk a little bit about that.
Okay.
Okay. So the at-risk zone, say it runs 0 to 40. It's not a super high risk, but it certainly could be a risk for maybe increasing stress, maybe some physical ailments related to alcohol as well. Could start to show up if you were to increase your drinking from there, or even stay there. This is a typical standard drink size over here. I'm not sure whether that fits your description of a glass of wine or not.
I filled the glass up, so maybe a little more than that.
Yeah, maybe that little space at the top. So perhaps a drink and a half each one. So that would also increase a little bit more. So perhaps maybe drinking more than you indicated on here. And for a woman, healthy woman your age, no more than 3 drinks in one setting is considered to be a lower or no risk, and no more than 7 in 1 week.
7 total in 1 week?
7 total in 1 week. And what you say here is that even on this sheet, you're perhaps already drinking more than that. So what do you make of all that?
That's news to me. I thought red wine with your meals is supposed to be healthy, and no more than 7 in a week. That seems kind of prohibitive.
Yeah. It seems a little less than perhaps you've been drinking, or what you consider to be healthy drinking. And certainly there's conflicting information out there about what's healthy and what's not healthy. I imagine the increased stress is what concerned Dr. Seal. As your stress increases, and if he were to prescribe you anything, maybe some interaction between the two that would also be a concern for him, I would think. So if you would, what is it that you like about alcohol?
Well, it does, at least in the moment, temporarily reduce my stress. And I you know, like a good glass of wine. I don't drink the cheap stuff. I like
Right.
the expensive.
Right. So you like the taste of it, and it does help to lower the stress, even if it's just for that time you're drinking. What are the not so good things about alcohol for you?
Well, you know, the nights that maybe I have couple more glasses than I should, I wake up feeling kind of yuck. And of course, part of my stress is finances, and I mentioned I like the good stuff, and so if I'm drinking more, then I'm increasing my financial burden.
Yeah.
So
So your financial stress may be increased by the fact that you're drinking.
yeah, kind of
Yeah.
defeating the purpose
Kind of a
there.
catch-22 there, drinking to reduce stress and increasing stress at the same time. So on the one hand it lowers it, and on the other hand it's increasing, kind of like a seesaw, teeter-totter effect there. What do you make of that, given that on one hand it lowers and on the other hand it increases, and now it's increasing even more?
And maybe I need to find some other way to deal with my stress.
Yeah. And I imagine you've had some thoughts of that. What have you thought of trying, if anything?
Well, I've exercised in the past, and that helps. Right now, my schedule is kind of out of whack, and I just really don't know what to do. That's why I came to see Dr. Seal. I thought maybe he could prescribe me something that would help me, you know, when I'm feeling overwhelmed.
And he may be able to. I'm not saying that he cannot. I'm just imagine that he's concerned that if you continue to drink on the level that you are drinking, that whatever he prescribes you, there may be an interaction with the two. I imagine that's his concern. I'm not completely sure. So you've had some success in the past with changing behaviors, and if you were to decide to make any changes here, it sounds like you could draw upon that to make those changes. How important would it be for you on a scale of 0 through 10? I have a little kind of visual here of that. If 0 is not important, 10 is very important, to do something about your drinking right now.
Well, I mean, if it means that it's increasing my stress, and or he's not going to prescribe me anything because of my drinking, then it's fairly important. Maybe about a 7.
That's pretty up there. Why did you choose a 7, not a 5 or a 4?
Well, again, I've got to get things under control. You know, my kids are dependent on me, and I've got to go to work to help ease this financial stress, and so, you know, all those responsibilities.
So there's a lot riding on your decision here on what to do with this. What, if anything, will bring it up to an 8 or 9 on that scale?
Well, the risk that you mentioned about the drug interaction, I certainly can't afford to, you know, have any more stress. So.
Yeah. So you choose to lower your stress rather than increase it, and if lowering your drinking would have that effect, that's something you'd be willing to do right now. How confident are you that you could do something about your drinking?
I'm pretty confident. You know, probably about a 7 or an 8.
Okay, so it's pretty high up there again. And what if anything would you choose to do? Would it be to cut down? Would it be to quit? I'm just curious about what
You know, like I said, I like a good glass of wine. I don't want to quit altogether. I'd be willing to try cutting back. But now, if Dr. Seal would agree to prescribe me something for the anxiety, and it meant that I had to not drink at all, I'd be willing to do that at least for a period of time.
So you'd be willing to stop altogether if that's what was indicated by the physician. Okay. So based on that, how ready are you to do anything right now, whether it's to cut back, whether it's to quit?
Well, again, you know, if I can get something to help me manage, if maybe I can find some other way to deal with the stress, then you know, I'd be pretty ready. Again, maybe about on that scale, maybe an 8.
Okay, so that's pretty high up there as well. It sounds as though you're pretty motivated to do something about this right now, given your responsibilities, given your children relying on you at this point, and just on lowering your anxiety in general. It sounds that that's one of your goals as well. Well, I'm pretty confident that once you decide to do whatever it is you decide to do, you'll be able to follow through with that, based on your experience in the past of making behavior changes. I imagine there's some things there you can draw upon. What's one thing that you could do? I imagine you thought of some things that might help to lower your stress.
Well, you know, the exercise, but again, that's kind of difficult to fit in right now. Hoping that Dr. Seal will prescribe something for me to take when I'm feeling particularly overwhelmed, and maybe just having somebody to talk to
Okay.
bounce some things off of.
One of the things we can offer here is for you to come in and talk to one of our behavioral health specialists, who may be able to help you talk through this area of your life, this area of increased stress, and sound like responsibility there. And we can make an appointment for you if you like, before you leave today, to talk to somebody.
That'd be nice.
Great. It also has some information here if you're interested, a pamphlet on alcohol and how what healthy limits are and how you can be affected by medications that you take as well.
Okay.
And I wish you lots of luck. It sounds as though you're really committed to making this shift and this change. And I imagine Dr. Seal will want to follow up with you and see how you do with your change within a few weeks.
Okay.
Again, I look forward to speaking to you in the future.
All right. Thank you very much.
You're very welcome.
Wow, what a difference.
Well, hi, Miss Clark. My name is...
Do we agree that Alan, the counselor, did a better job? His second time around? He was non-judgmental, he was educational, affirmational. He also used the ORS skill. He asked open-ended questions, he gave her affirmations, he reflected on what she said and summarized. Also, did you notice her body language? Her body language was open, she didn't have her arms folded, she physically turned away from him in the first one. So you could see how when he used that, it made a difference he got her to make an appointment. And she really thought about reducing her stress level and how she was kind of medicating with the alcohol to reduce her stress. I feel so much better. I hope you do too. Can we go to the next one? Any questions about motivational interviewing?
I have a question.
Sure.
What happens like when the client starts to get aggressive? Like I know in the video she was pretty calm, but sometimes like when we have these conversations with clients, they start to get like verbally aggressive and like, start to stand up or something like that. Like how would you suggest that we go about that?
Yeah, actually it's interesting you brought this up because I had this very conversation yesterday and today in supervision with one of my staff about, we want people to see the need, right, for change and how we have to follow rules and directions and different things. I would certainly speak to your supervisor about it, and I would surely I would speak to your supervisor most definitely, but I also would safety is really important. And you need to feel safe when you're working with your participants. Can I ask you another question? Where do you meet in the office only, or do you go out and do any type of community home visits or anything like that?
We do both.
You do both. Has this happened to you in the past?
Yeah, I had like a recently, maybe I want to say maybe like a month or so ago, a client who was using, and the conversation kind of we didn't address her usage, but she was already upset. So then she admitted to using, and then we were trying to like talk to her about it. But we were in her home, and she wasn't getting aggressive towards us. She was getting aggressive towards her partner. So it was just not a good scenario.
And thank you for sharing that. I'm sorry, who jumped in?
It's Madison. I just wanted to me and Allie are on the same case together with the same client, and I can second that notion of what she was saying. I find as though it is hard when you're working with clients and you're trying to help them, but then when they get angry and very aggressive, and then like Allie said, it wasn't directly towards us, but then it got to the point where it was like it could start being directed towards us, the aggression and the anger.
Definitely. And let me be clear, safety is first, right? You don't, at that moment, anything that you would say to her is probably not going to get her to engage in motivational interviewing with you about it. So I would certainly say table that for another conversation when she's calm and you both know that you're safe and that you can actually have that conversation. It can't happen all the time. And I love that you brought this up because this was really important to say. Not everyone is ready to hear, like if we looked at the first video where, he came at her completely differently. And for you guys, you walked into something, I'm imagining, that was going on that, happened before you guys got there. And then you're there and, it just added to it. So, safety first, motivational interviewing when they're ready to hear it.
Thank you.
Any other questions?
Sorry, if I could just add in, if you're ever somewhere and you call the main office and your supervisor is not here, ask for the administrator in charge, and we will send somebody over immediately. If you're finding like you're having a hard time to get out, we have a lot of clinical staff that we've asked to also partake in being supportive, because we don't have the budget or the number of staff. We'd always want to be able to send in pairs of two, but that's something that can be strategized down the future, that you go with housing, or you go with the peer if they're assigned through independent living, or you go with, say, their clinician or something, because if you've experienced it, I'm pretty sure other people that provide services to these individuals have also experienced it. And that's why our commitment from that Welcome Orange approach is that we do these things together. And as Barbara said, safety first. There's nothing wrong with saying, oh, you know what, I'm getting a call, or, whatever, we don't have pagers anymore. But something that just says, you know what, I need to check in, and, I'm not taking this personal. I understand it sounds like you're going through a very frustrating situation, but get yourself out, because at that point, as Barbara said, it's not really where you're going to engage and change any of the thinking, versus let's figure out what is needed to support this person. Because sometimes when the drinking is involved, that's where safety we would be concerned about. And even just the idea of having those conversations when you come back, let's talk about what happened the other day when I was here. What I found was you were honest with me, and I appreciate that you're going through a difficult time. So, how can we build off of that trust? It's the fact that in that moment, it's probably not the great time to have a conversation. But so don't hesitate to call us and say, can you have somebody come over here? We'll work with you as well. And remember too, the mobile response team, calling 311, just say, you know what, this seems a little bit more than what I'm able to help you with today. Have you ever had the mobile response team? Why don't we give 311 a call? Why don't we get you some support right now as well? So you're not doing it by yourself. But you also have to be honest with the MRT or the call center. If there's any threat of violence, they will have to come with the police. They cannot go by themselves. And so they're asking for the call center counselor, when asking for MRT, to share if they believe there's any history of violence or any potential for violence as well. So just something to keep in mind as well. But great question.
Thank you, guys. So
I have a question.
Oh, another question. Yes.
Sorry. So my question is, what if you have brought it up to your supervisors and the response you get back is, well, this is the field you work in. What do you say to that?
Can I ask you a question? So you are going back, just so I can clarify, you're going back and you're sharing with your supervisor what just happened on a visit with one of your clients?
Yes, like a visit, you have a talk with the client, and certain things, you express to your supervisor, and, you get a response as, this is the field that we work in. Unfortunately, there's things you have to pretty much tolerate.
I just did a deep breathe because that, for me, that doesn't feel so good. And I think that we can't put everyone in the same category, right? Any of the work that we do is not cookie cutter work. All of our clients are different. And right, we're different as individuals. There's some things that I excel at, there's other things that I'm not good at. And I think that the more that we do trainings like this, the more you're gonna have the tool. I look at it as an invisible tool belt, right? Remember who had one? One of the characters, superpower characters, had a tool belt. I look at it as it's a tool belt of, oh, if this happens, I can pull out my tool belt and I'm gonna try to use this. So I think that for me, I would say that would be like a further conversation to kind of figure out how you can meet your client where they're at, be effective, right, in what you're doing, and not feel that whole thing. It sounds really stressful to me, and I'm sorry that that happened. But I think I would suggest a further conversation.
So
Thank you for the question.
if I could just add in, the statement is very, very true. We got to look at the nature of the people we serve, the positions that we have signed up for, and depending on the program, the intensity of the client. I think about compeer visiting is more of a friendly visitor type of interactions. You might go to the grocery store, you might go to do laundry, you might go to the library together. And then you move into the case age, dropping off groceries, all the social determinants of health and that support there. Then we get into the case manager for housing. You think about how scary it can go sometimes going into people's apartments, into housing, doing the inspections, that kind of stuff. You go into home to stay, where the nature of the people have failed out on all other types of housing. And that is what we have signed up for with the higher needs. Think about health home to health home plus the higher need. You think about Hudson House and some of the individuals that have come straight from incarceration, that probation accepts coming to Hudson House as the terms of their release. So the nature of the work we do is where we do have clients that might be a little bit more difficult, but it goes back to what Barbara said with those tools, those resources. And so when a supervisor actually says, this is, what MHA is funded for, this is what MHA's vision and mission is to support, is let's figure out, do you need more tools? Do you need more training? Do you need more opportunities to figure out how best to interact with the client? Because like Barbara said, if we paint everybody with the same paintbrush, that everyone is a certain way, then when we even approach, we have to put ourselves at check as well as how are we communicating with the clients and what impression are we giving them that we, feel about them. So we want safety first, but we also have to acknowledge this is what we did sign up for. And this is what we have senior positions to support people in programs that have multiple staff to, mentor and, what did you do in this situation? That's where we want always. And that's another reason why we're doing these trainings, how best to support staff in those difficult situations to feel equipped to have those conversations. But don't stop talking to your supervisor. Just acknowledge that at the end of the day, if there's something you're missing, let's figure out how we get you those resources and tools as well.
I just want to step in that we have a scale of supervisors. So some programs have supervisors, program managers, assistant directors, directors. We have Angela as executive director. Please always feel the open door policy to go talk to a supervisor. If you're not getting the support you need from your supervisor, please go to another one, to anyone, to express how you either feel unsafe or feel that a client is doing something that you feel they shouldn't be. Please don't feel that you can only go to your supervisor. You can go to anyone of the agency to get the support that you need. I just wanted to throw that out there.
Absolutely. So I do want to introduce Trish, but first I also just want to chime in my 2 cents. I can imagine we looked at those 2 interactions that Barbara shared with us, and those are really good videos. I'm going to steal them if I ever do a training like this again, Barbara. It was great. But I can imagine if you didn't go in with the tools, like in that first video, having that interaction over and over and over again could be exhausting, right? But if you do have these tools and you're part of these trainings, and you go, and some of it's just learning and watching people who have been in the field for a little bit longer, because it's so much nuance about the way you say things or the way you move your body and paying attention to people and just coming at it with respect. Shame and guilt are incredible buttons for every human. And a lot of what we're doing is just trying to avoid those buttons. buttons in people. And that can be hard when you're talking about big things. So it definitely is not easy, this work that we do. It's incredibly rewarding, but you do have to get that invisible tool belt, as Barbara said. So next, we're going to be talking about when those situations do go wrong, or you walk into something like the first question, where it's already escalated. What do you do at that point? And for this part of the presentation, we're going to have our other two assistant directors, Trish and Caitlin, who are both a longtime staff at MHA. And what is great about that is that they have come from direct service or direct administration all the way up. So they really know what it's like to be in your shoes. At Hudson House, I think that's where Caitlin started. They are very familiar with the programs and have been with us for a while. So they're great resources, and they're always, I don't think either one of them have ever not picked up when I called. They're always available. So I'm going to hand it over to whichever one of you is starting next.
I'm going to start first. I see a lot of blue on my screen, Allison. Does everybody else see that? Yep, whatever you're touching now. Perfect. So the agenda is we're going to go over crisis intervention and techniques, de-escalation and techniques, active and reflective listening, strategies, and coping techniques. I'm going to talk for a little bit, and then Caitlin's going to take over. Oh, I need you to move the other blue thing too. Sorry. Thank you. Oh, it's still
Are you
there.
good? Can you
Yep, now I'm
see?
good. Perfect.
Okay, great. It was just your faces. I can't see your faces. That's all right.
Introduction. So a crisis can refer to any situation in which the individual perceives a sudden loss of his or her ability to use effective problem solving and coping skills. Several events or circumstances can be considered a crisis: life-threatening situations such as natural disasters, an earthquake or tornado, sexual assault or other criminal victimization, medical illness, mental illness, thoughts of suicide or homicide, and lost or drastic changes in relationships like death of a loved one, divorce, something like that. Crisis intervention. Crisis intervention is the urgent and temporary care given to an individual to interrupt the downward spiral of maladaptive behavior and return the individual to their usual level of pre-crisis functioning. Crisis intervention also refers to the methods used to offer immediate, short-term help to individuals who experience an event that produces emotional, mental, physical, and behavioral distress or problems. The purpose of crisis intervention is it aims to reduce the intensity of an individual's emotional, mental, physical, and behavioral reactions to a crisis, help individuals return to their level of functioning before the crisis, improve functioning by helping them develop new coping skills and eliminating ineffective ways of coping, such as withdrawal, isolation, or substance abuse, assist the individual in coping with future difficulties more effectively. So in crisis intervention, you want to teach them also how to deal should they come into a crisis without you there. Next slide. The guidelines for crisis intervention is the immediate intervention will interrupt a prolonged crisis. So you definitely want to intercept early on in the crisis to hopefully avoid the prolonged crisis. Be active in helping, exploring, and resolving. Focus only on goals related to addressing the crisis and build hope and expectations, hopefully a resolution if possible. Crisis intervention also is to foster support because lack of it can lead to increased negative outcomes. Focus on resolution of solving the problems for the underlying crisis. By that, like if the crisis started because they ran out of food, setting up food pantry for like a weekly or monthly delivery to avoid that. Or if their medications ran out, so they stopped taking their medications, the crisis arose because of that, you want to help prevent that from happening in the future. Build self-image and self-confidence. Crisis for people with mental illnesses. Most people with serious mental illness have symptoms that change over time. They get better or worse as a result of normal life stressors. The nature of symptoms can lead to a crisis. Many people with serious mental illness have difficulty coping with stressful situations. And when a person stops taking medication, symptoms often increase. Many people with mental illness, a stressor that people that don't have a mental illness might deal with a stressor much more calmly than someone with a mental illness. The logic of de-escalation. If you take a less authoritative, sorry, Allison. If you take a less authoritative, next one, thank you. Less authoritative, less controlling, less confrontational approach, you will actually have more control. You have to try to give the consumer a sense that he or she is in control. So then in a crisis, they feel very out of control. So you want to like have them feel they are having the coping measures that are giving them that feeling of controlling, because their normal coping measures are not working at this time. Next slide. And then I think Caitlin is taking over here.
Yes. So the guidelines for de-escalation, first, we want to make sure we're maintaining a safe distance, especially if we have a client that's walking around, they're angry, like we want to make sure we have our own personal space. We want to use a clear voice. We want to use a low volume voice. I know a lot of times, like the goal is for them to match. I don't know where those slides went. But basically, we want them to be meeting and matching our tone of being like calm and collective. I know a lot of times when someone's like screaming at you, like it's very easy to like match their tone. So instead, we want to set the calm tone that they will hopefully come around and match. We want to set limits. So that's another example in that situation that like Allie was talking about. Like if you feel unsafe, just getting out of there immediately, whatever excuse you have to make. However you go about it, just first prioritizing your own safety and setting limits depending on the situation. You want to use relaxed, non-threatening posture. Next slide. You want to be active in helping, like what Trish was saying. If there is an underlying problem that's causing the crisis, like what can we do to try to solve that problem? It's always important to focus on their strengths, being compassionate, trying to offer choices, again, trying to present yourself as like a calm influence that they will hopefully match later on in the crisis. Next. We want to remove any distractions or disruptions, anything that's upsetting them further. If we were in their home and maybe they're upset and something in the home, like the partner is upsetting them, maybe we can get them outside the home and try to like separate them. Again, being aware of our body language, we want to be like relaxed and opened, like if you have like your arms crossed, like anything like that, like you're sending a message if you like whether you realize it or not. And back to motivational interviewing, it's important to listen and repeat back to show that you understand. But also with MRT and police officers, if they do become involved, to remember that those can be very intimidating. You want to use I statements, focus on like what's going on right now. Don't want to make any promises you can't keep. Like if you have a client that's homeless, you don't want to be like, oh, we'll house you. Like you have to make sure that anything you're saying is something that they can trust and that they're not going to use it later and be like, oh, but you said you would house me, but you were just really just saying that to like stop the situation. So just being honest and as helpful as you can. Next slide. We want to recognize that someone's struggling mentally. It can be very overwhelming. And it's also important to go back to Maslow's hierarchy of needs, we might remember. Just trying to figure out like where the person is within there. Like I think a lot of times we want someone to work on themselves, find employment, do what they need to do to better themselves. But if they don't have housing and they don't have food, they don't know where they're going to be sleeping, then those aren't very like realistic expectations. And we can't be expecting them to do higher level things on the pyramid when like their most basic needs aren't being met. So just trying to keep that in mind as well. Next, back to motivational interviewing. We want to be paraphrasing, asking open-ended questions. Sometimes silence is good just to show that you're like thinking, that you're listening. So just an example of stating back what the person is saying. So if the person's saying, I stopped taking my medication after I was fired and now I'm sleeping in my car, we can go to the next slide. We could reply back, okay, I hear you recently stopped taking your medication, you lost your job, and now you don't have a place to stay. So we're feeding back that we're listening and understanding what they're saying. Another example would be like, I'm afraid of sleeping in my car. How am I going to get an apartment without any money? So something we could respond back to show that we understand what they're saying is you're feeling scared and depressed because you don't have any money and you don't have a place to stay. So that is definitely showing that we understand that they're going through a lot right now, and it's understandable that, you know, they're upset right now. So next is some strategies to keep in mind when working in some specific cases. So if you're finding yourself with a client who's in crisis and they're having disordered thinking, maybe they're verbally aggressive, we want to allow the person to vent, maintain a safe distance, talk in a low voice. We could do the broken record technique. We're just kind of repeating something specific back to them to kind of just like keep them like in the conversation. Like if they're going on like side tangents, like you could just like keep repeating a phrase. Like an example would be, I had MRT and police come out to a client and he was like talking, he's like upset, he's walking around. So I just kept saying like, the police are asking you to sit down. And he would like keep going, he'd keep going. And then I'd be like, okay, the police are asking you to sit down. Like, can we sit down? And then we can like come back to this. So just repeating yourself if needed. Hallucinations, you could validate that the person that they're having this experience and that you don't hear those voices. Like you could even say like, that sounds, you know, very scary. I don't see that as well. But I can understand how frightening that could be. There's actually a person on TikTok, he's like an artist and he has schizophrenia. So he has a page where his like whole art is dedicated to him trying to give like the stimulation of like the simulation of having a hallucination. So it might be helpful to check out, but it's really scary. So I could definitely understand if someone is going through that and they're like seeing things, they're hearing things, like, you know, it's going to be very hard to like get them back on track and try to help them because they have all these like internal forces like working with them as well. For people with like delusional statements, paranoia, you want to recognize their view, indicate that it's not your view, but you're willing to help them. You don't want to argue or debate, and just focus on the person and like what you can do to help them. So you could say like, oh, like I don't feel that way. Like if you have someone that's like paranoid, but you know, like that sounds scary, but I'm here to help. Like, how can I help you through this? Next slide. So if you have someone that's going through mania, you want to ask concise, specific, concrete questions. Again, another time to use that like broken record technique. Intoxication, you want to assess for safety of the situation first, as the visit will probably likely need to be cut short or like ended. You definitely want to let your supervisor know too, but if it is appropriate to stay, you could let them vent, listen, use a calm voice, move away from the person, just try to be reassuring. But in most situations where like substances are being used, I would say probably just get out of that situation. And then with someone that's going through depression, you want to actively listen, show empathy, take time, reassure, offer hope, and validate their feelings. Does anyone have any questions so far? Okay. And then my last few slides are some just coping techniques that could be explored. This first one I saw someone do when I worked at the call center, and I thought it was, oh wait, no, that's my next one. Okay, first, breathing techniques. It's always good if someone is, you know, upset, to encourage them to take a deep breath or take several deep breaths, because when they don't, you know, holding in your breath can just lead to further like increased heart rate. Next, all right, not the next one. The next one is safety planning, which I know there's some like back and forth on the research about whether it is actually helpful, but I don't think it's ever a bad idea to discuss with the client, like, who could you call if you're upset? Like, is there any hobbies you can do? Like, oh, you like journaling? Like, I think it's like a good conversation that can be helpful about, making a plan if something's going on, like who they can call, what they can do, like writing down any important numbers and just like having everything on one page. Oh, the last one. This is the one I saw someone do at the call center, and I thought it was really cool. But someone was like on the other line, they were very upset. So they had them do like a grounding exercise with different senses and like things they could see. And they were like having the person like tell it back to them. And it seemed helpful. So I think that is all I have. Does anyone else have any techniques or questions or anything?
I have something. When you were talking about the safety plan, you weren't sure like if it was good or not. A safety plan is actually really good because my son, we have a safety plan set up for him at school, and it kind of gives him the sense of being in control. So like when he's having a behavior, he can go to his safety plan and follow the steps that, and it actually helps him calm down and gets him back to his baseline. And I think it's very good because one of his on his safety plan is if the first thing he does is take deep breaths. If that doesn't work, then he goes for a walk. And if that doesn't help, then the next thing is to call one of his parents to help him calm down. We don't normally get to the third one where he has to call us. The walking kind of calms him down, but safety plan is really good to have in place for clients who need it.
Agreed. I like it too. And you could print out a bunch on the internet and like find one that is like what you're looking for.
We have more in the chat saying that there's a safety plan has been helpful. I think having goals written down anywhere is super helpful. Does anyone have any questions or any anything else they want to bring up before we end today? We can go back to motivational interviewing. If you've had a hard time with a particular situation, this would be a great time to help use your resources to solve that. All right, I didn't count all the way to 10 that time, so just interrupt me if you were waiting for that 10th count. I don't know, it seems so much longer when we're online. So the last thing I want to say before I let everybody get back to your last little bit of work for the day, I remember next time our next session is in person, and I'm dropping the sign up in the chat. If you registered for this, you really didn't have to register for the first two in order to attend. For the third part of this, you absolutely have to register because it's in person. We're going to be interacting. You guys are going to be doing case scenarios and role playing. So if you need to psych yourself up for that, you got some time to think about that. But we do need to know how many people are in each location because we will max out. Oddly enough, the Middletown conference room, the occupancy is actually higher than Hudson House. Crazy things. This is how it's classified in the building code. So we do need to make sure we have enough space for everybody. So please register. The first few questions is answer yes or no, whether you came or not. Don't worry about it. I didn't make a new sign up just for the third one, but it is important that you use it. So share it with your colleagues that are not here. I'm also going to be sending it out when I send out the recording of this video. And I just want to thank you all for coming. Is Angela still on? I wanted to give her an opportunity to just say anything she'd like to say if she's still here.
Yes, I'm still here.
All right.
I want to thank everybody for taking the time. I know that it was discussed around the call center and that, and these are things, techniques that they use on a regular basis. Even if you're doing your credentialing for alcohol and substance abuse counselor, there's a lot of work and mandated trainings on motivational interviewing. So a lot of this stuff is just not the agency saying, hey, you should do this to do a better job. It's the fact that we want to give you the best opportunity with resources and tools and for you to feel comfortable and confident. And I trust you when you start to use it, you'll find that it gets easier and easier just to go back to those resources. So again, thank you to everybody for taking the time.
All right, everybody. We'll see you in part 3 in person. Enjoy. Have a good day.